Do you want to stay ahead of the next pandemic? Here's a quick update on measles to Marburg and everything in between. Dr. Tyler Evans is an infectious disease and public health physician who currently serves as CEO and co-founder of Wellness and Equity Alliance. He's led major initiatives at Curative Incorporated, Marin County Health, and New York City's COVID-19 response. He oversaw the delivery of over 2 million vaccine doses nationwide and has deep expertise in HIV/AIDS, refugee health, and global infectious disease through work with Doctors Without Borders and the AIDS Healthcare Foundation. He's the author of Pandemics, Poverty, and Politics, Decoding the Social and Political Drivers of Pandemics from Plague to COVID-19, which explores how social and political forces shape the spread of disease. Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Dr. Tyler Evans, thanks so much for being on the podcast.
Yeah, it's great to be here. Thank you for having me. Really excited. Looking forward to this conversation.
I loved how genuine that sounded. So before we get started, I love to start with a story, right? And I'm sure you, in what you do, you have lots of amazing, poignant stories. So let's start with an example that demonstrates the benefits of the important work you do, like something on an individual level that can help our patients understand what it is you do a little better.
How about two?
Two stories. We're negotiating. Two.
I'll give you more of one sort of a micro and one sort of a macro. And so the micro is more just me as a doc working in some of the sort of the foxholes of global health crises. So I was in South Sudan working with MSF, Doctors Without Borders. I was the only doc for 29,000 IDPs, internally displaced people or refugees. And that translated to me just never sleeping. And a concrete sort of benefit that I had to help build, I was there to build a pediatric malnutrition hospital. Now, I'm neither a pediatrician nor a nutritionist, so I had to figure out a lot of this stuff on the fly. But I did, because as an infectious disease trained physician, I did learn to build out some things that I did actually understand, which were a TB program and a visceral leishmaniasis program, which is otherwise known as Kala-Azar. And it's an infection that usually adolescents, youth are infected by. It's transmitted through the sandfly. And it was because we were right next to the Nile River. So I saw all these kids with these really large spleens, and the disease detective in me said, all right, that's weird. What's the sort of pattern here? And so I just started to track these sort of patterns. And really the differential was relatively narrow. I mean, there's really 4 to 5 top diagnoses here, and ultimately did a little bit more research, and it turned out visceral leishmaniasis right next to the Nile River. I needed a water source was likely the cause. The good news is there's a treatment. And so we got dozens of these kids treated and went on their way. And ultimately, as other MSF crews got in there, they basically were focusing really heavily on that. So
that's amazing.
Like one example of just being in the fields and just thinking through medicine, particularly in the US, so much of it is sort of hospital based, so much of it is procedurally based. We have so many diagnostics available to us. We don't think through the sort of our diagnosticians' abilities have waned, I think, and we rely too much on the medical apparatus. So just being in there and being able to really think through these and help folks was great. On a macro level, working as the chief medical officer for New York City during the COVID pandemic, I guess really working between City Hall and other kind of policymakers or whatnot, and then working with communities and being able to provide access and keep people out of harm's way was a pretty compelling experience for me, and just allowed me to help address this system, which I often say that I still see patients, but I've replaced a lot of my individual day-to-day duties to basically working on a more systems level. So I treat the system as my patient. The system is sick, very sick, and it's getting sicker. And so that's just examples of how I kind of approach healthcare.
And ultimately, that's the way you scale your own skills, right? You can only treat one patient at a time so efficiently, right? Maybe you can see one patient every 20 minutes, you get faster every 18 minutes, every 15 minutes, but you're going to hit a maximum there. But the way that you scale your own skill set and knowledge is by working on a more systems approach. So you can have more impact.
Exactly. Yep.
The main theme of today's interview is going to be just an update on a bunch of infectious disease that most of us haven't seen in our residency. We read about it, we were tested on it, and then we forgot about it because it hasn't been around. And now, unfortunately, because of waning vaccination, they are back. In addition to some new diseases that we might not even heard about. So we're going to be talking about measles, whooping cough, bird flu, mpox, Marburg virus. Hopefully we'll have time for it all. Stay tuned. Okay, so let's start off with measles, right? Just where do we stand right now in the US? As of today, we're at the end of April. The episode will be coming out in a week or two. So where do we stand right now in the measles pandemic? What do we call it at this point, actually?
Not pandemic, epidemic.
Outbreak. The measles outbreak.
Outbreak. We could call it epidemic. Epidemic is any number that sort of increases beyond sort of endemicity. So it's rightfully an epidemic. Pandemic would be, and just to
right.
Yeah, I mean, epidemic that essentially crosses transnational sort of epidemic. There's some more complexities to the term. And in my book, I define pandemic in a certain way. There's a few different ways to define it. And so I looked at essentially any epidemic between 1899 to the present that basically went through this particular rubric. I defined it as infecting at least 1 million people, but there's a few ways to approach it. But back to measles, we're not looking great, but it's not as abysmal as a lot of folks think. It really just comes down to vaccine coverage. And as we know in Texas, a lot of the reasoning behind the outbreak was one particular community, the Mennonite community, that have some different beliefs on vaccinations, did not have optimal vaccinations. And so particularly in rural areas, particularly in those areas, they were more at risk. And so we've been seeing, given the risk of measles infectivity, we define it as an R0. Essentially, you want me to talk about that?
Sure.
R0 is just basically somebody walks into a room who's infected with measles. You got 100 people in a room. How many people, they sneeze, how many people are they going to get sick? So the R0 for measles, which is one of the highest when we're looking at infectious disease, particularly respiratory disease, is not airborne, it's through droplet transmission. It is somewhere between 12 to 17. So very high. And for comparison, influenza is somewhere between 1 to 2. Typically, it depends on the seasonal components. But
just to flesh out some of the terms you just used. And so the R0 is assuming you have a completely unvaccinated population. So you're going to, in each person that gets measles is going to transmit it to anywhere between 12 to 17, assuming that everyone that they encounter is unvaccinated, correct? They don't have vaccine protection. So you sneeze in a room full of vaccinated people that have competent immune systems, that number is going to be very different. So there's that. And then they mentioned droplet versus airborne. So actually, these are all conversations that we had on the show at the beginning of COVID, when we were trying to understand what the heck was going on. So we had these conversations then, but thankfully it's been a while. Droplet it's in your mucus, but the mucus responds to gravity. So it can only stay in the air for a short period of time before it hits the ground, and hopefully nobody's licking the ground and getting sick. Whereas airborne would be more like tuberculosis, where it defies gravity and remains in the air for a prolonged period of time.
Exactly. And that's the sort of the mechanics of the droplet is just, you said, it's really just, it is impacted by gravity and by the size of it as well. And the droplets, typically the trajectory is going to be around 3 feet. With the COVID pandemic, we just doubled that. In the beginnings of the sort of the pandemic, I was in some of those rooms and we literally just doubled it to 6 feet.
Listen, that's what they do in engineering. What's the maximum weight that this can hold? Double that, or rather half that. And that's what you write down as the maximum weight it can hold. It's not like you just made up doubling. That's something that's done in engineering. So there's some history there between the number 2.
But part of the reason is because we know humans, especially New Yorkers, where I was, are going to challenge boundaries. And if we say 6, it'll probably get down to sort of 4 or 3. But it's interesting when you then translate that to the metric scale, but in most countries, seeing how what that number translated to exactly. But yeah, so that's droplet, airborne. Some sort of the sort of quintessential sort of example of airborne is TB. Much smaller. They're not really droplets, much smaller sort of microbes that are essentially airborne, and it's diffuse. It's in the air.
Didn't we find with COVID, which is droplet spread, also it did go longer distances? Cases were
So you were somewhere in between the sort of the airborne, and nothing is really ever binary, as we know.
Yeah,
right.
Didn't read the book. That's what they tell us in medical school. Coronavirus, didn't read the book. Okay, so then so it started in this Mennonite community, which was largely unvaccinated because of what they believe. And then because the R naught is so high, and Texans being Texans, especially in rural areas, also freedom, so they have low vaccination rates. So then it spread to more people.
Yeah, that's exactly right. I mean, that is, and it really, now in the US, where we have historically had measles vaccine coverage typically greater than 95%, certainly in urban areas. Rural areas, that number is going to dip a bit. But because our vaccine coverage has been so prevalent, you get to that sort of herd immunity component, which I'm sure you guys talked about quite a bit. And where ultimately folks who are not vaccinated, it ultimately doesn't matter because so many people are vaccinated, the likelihood or the probability of you coming into contact with somebody who is not vaccinated is just so low that it's almost impossible.
Okay. So we shouldn't be freaking out about it because it's going to hit these walls of herd immunity, because herd immunity is not a static thing. It's a dynamic thing. So if you've got a certain population that has herd immunity, someone with measles comes into that area, maybe they infect one person and then it stops there.
That's right. Yes. So our emotional responses in the medical community, our emotional responses should be somewhere between being concerned and being moderately to extremely concerned, particularly in the more sort of rural areas. Freaking out should not be a part of that sort of emotional response.
I'm thinking of that like pain scale, right? You're describing the freaking out scale. Okay. So then is there a role for a booster for certain people? Because what I'd heard was if you're born before, I think it was 1989, you got one measles vaccine. If you were born after 1989, you got two, in which case then you're protected indefinitely. Maybe if you were born before 1989, you should consider getting another one. Don't go by titers. It's easier to just get the booster than have titers drawn and follow up. So what are your thoughts on that?
It all depends on risk. I would say as a healthcare worker, if you are in the weeds, particularly I'd say as a pediatrician who's working in rural settings or something like that, and this one's important. If you are looking at local prevalence of any measles outbreaks, if you are in that area, absolutely, I would say go get a booster. No, there's no issue with that. And that's in fact, when we had a mumps outbreak in LA, where I used to work, and it was particularly around men who have sex with men. And we were just basically, as opposed to doing the titer, which takes time and whatnot, we just said, go ahead and get the MMR because it's the same vaccine again. So yes, agree with that. If you are in an urban setting where the vaccine coverage is very high and any sort of recent outbreak is very low, unless you're in certain communities like Rockland County or Williamsburg, then you should be fine. And I would not recommend getting a booster, irrespective of what year you were born.
For context for the listeners, those counties, those particular places have large populations of Orthodox Jews where they tend not to vaccinate, similarly to the Mennonite community.
Yeah. And importantly, though, for the Orthodox Jew or the population, it's not vaccine hesitancy per se. It's not that they don't believe in the science of vaccinations. That's a really important to just. I lived in Israel for 3 years. Their vaccine coverage, typically among the Hasidics in Israel, is actually quite high. In the US, though, because there's a disconnect, folks living off the grid and whatnot, that's essentially the reason why a lot of folks don't get the childhood immunizations.
Got it. Interesting. So it's not because of their politics, because that they tend to lean right, and now we're seeing more people on the right not get vaccinated. It's not that. It's just they're just off the grid. And so because they're not involved in the school systems and whatnot, they just don't have these entry points. Got it. Okay.
But I would, just to close that out, so if you're a physician working again in an urban setting where there have not been any sort of recent sort of outbreaks or any concerns, there's no need to get that booster.
Got it. So in the Northeast, there was someone who took an Amtrak train from Boston to Washington, D.C. So if you happen to be someone that lives between Boston and DC, it doesn't mean that now you have to get your vaccine. We're looking for where are these things springing up, and then maybe consider getting, especially if you might be exposed to it, right? You're a radiation oncologist, probably not. You're a pediatrician, emergency medicine, something that deals with upper respiratory tract infections, then that's a different story.
Yep.
Okay. Yep. So do you think...
I would just say as a patient, which as a physician, occasionally we are patients, If you are immunocompromised or pregnant or any other reason that you were increased risk, then I would say that you may want to talk to your primary care provider about that.
Makes sense. So let's move on to whooping cough, because that apparently has become much more prevalent as well. And I think we're having a big outbreak of whooping cough that's not really making the news like the measles is.
The variability of media coverage on infectious disease outbreaks is interesting. Sometimes we shift for certain reasons and shift to the left for other reasons. The reasons behind any outbreak for whooping cough or pertussis is the waning immunity. And we typically find that waning immunity starts to really manifest at least 5 years beyond their last vaccination. So if somebody is around young kids where there's a higher risk of pertussis, particularly if those kids have not been vaccinated yet, then they're naturally going to be at risk. And then that could scale up as the result of that chain of transmission. The reason why we don't probably talk about it as often is because the lethality, the sexiness of a new sort of innovative novel strain or whatnot isn't there. That's my own assumption. I don't really have any other strong understanding as to why it wouldn't scale like a COVID-19 would.
Wait, what do you mean scale? Like why it hasn't hit the news?
Yeah.
Oh, okay. But tell us anything more that you know about the outbreak that we should be aware of.
I would just say that the waning immunity is the most important piece that folks should be concerned about.
Got it. Okay. So I did an episode maybe 6 months ago about bird flu, H5N1, and now that doesn't seem to be in the headlines anymore, at least not consistently. We've seen that happen in the past, not with its prevalence in the news cycle, but with its prevalence in the US, where it just you'll have an outbreak and then it'll just, for unknown reasons, just stop. Is that what's happened now, or is it just not being covered?
So it's probably a little bit of both. And there's going to be a theme to a lot of these. And we're going to see it's going to be worse in the future what this theme is. And really, it's the impact to public health infrastructure and our surveillance systems. Because of the significant cuts that are taking place, we are not going to be able to be tracking a number of pathogens out there. This just came out, for example, on not testing dairy products, specifically milk, as often. As a result, you've heard of this?
Yeah, and Trump made that very clear during the first pandemic. He suggested, why don't we just stop testing for COVID as much? Then we won't find it as much. He said it in a news conference out loud. And so it makes sense that they don't want these things because it's a bad look. If they defund these institutions and then these outbreaks happen, then it's a bad look. But if these outbreaks happen, but nobody's minding the store, nobody's looking for it, then it doesn't end up in the news and then they don't look bad. So this all tracks.
Yes. So exactly what's been going on with the milk piece, which we can see a number of microbes that would be at considerable risk for folks that are drinking milk that is not pasteurized. It's important to note, one of the most oldest public health surveillance methods that we've had, or not surveillance, but sort of prevention methods that we've had.
Pasteurization. Heat up your milk. Yeah.
So we've had these available to us, and yet now we are not leveraging the access and the ease of these, not just the application, but the surveillance of it. So just using that as a sort of comparison for it's the same sort of pattern that we're going to be seeing. There will be less talk of it because there's less surveillance of it. Now, having said that, when we look at the seasonality of H or influenza in general, we are now heading into summer. And so we're not going to be seeing the typical numbers that we would often see during the fall and whatnot.
But that's for human to human transition because we're living in closed doors. Does the better weather really impact the way animals interact with each other? Do they spend more time outdoors in the summer than they do in the winter and therefore transmit diseases to each other less frequently?
Oh, sorry. Are you asking about the
H5? Because there hasn't been human to human transition of H5N1 yet. So we're talking about it being prevalent because it's being transmitted from animal to animal.
But are you asking whether or not we're covering it in the media because humans are not getting infected as much, or in general, we're not testing the animals?
Both. Like why it's not. So my question, is it actually going away or not?
It is not going away.
Not forever, but are the cases declining would be a more precise way of saying it.
The cases seem to be declining.
Okay.
But again, there's a lot of
The
different reasons.
confounding factor that we're not testing.
Yeah.
So it's hard to say if it's real or an artifact of just not testing for it. But
Correct.
aren't there states that are testing for this that are not being managed by the federal government?
Are there,
Is that happening as well?
Yes, but because HHS basically cut budgets to a lot of these states, like California, Washington, these were two states that had a significant number of cases.
Yeah.
H5N1, they've had significant cuts to that.
Okay.
California, and I'm in the Bay Area, so California, our Department of Healthcare Services, DHCS, which is the state health department, has cut a significant number of jobs. So how that impacts surveillance, we're still playing that out right now, but it's absolutely going to be impacting our ability to surveil or screen pathogens like H5N1.
And what about
And there's
human
also,
cases? Because because there were like a handful of human cases.
Yeah.
And so I would think if there were more human cases, we would be aware of it, correct? Yeah.
You would think.
We keep running into this problem.
Yeah.
Okay.
For the audio folks, I gave a shrug.
Throw up his hands.
There has only been one confirmed death. And so in terms of that sort of alarm, that emotional response, that 0 to 10, facial expressivity, I would say we could be moderately concerned about this.
Okay. So where are we on that facial scale with mpox?
So mpox is a really important one. We know that the majority of cases that were taking place with mpox were between men who have sex with men or transgender females. And we were seeing cases that were mostly transmitted into your larger cities. We were seeing tons of mpox taking place, certainly in New York City, in Los Angeles. I was managing some programs in Austin, Texas. So we're definitely seeing it in key areas. The good news is a lot of it died out in the US in terms of human-to-human transmission. The bad news is it reared its ugly head in other areas of the world, particularly in sub-Saharan Africa. So last year, we were really concerned about mpox in DRC, Democratic Republic of Congo, as well as other areas throughout sub-Saharan Africa. And we would see outbreaks every so often in these areas, particularly during certain sort of seasons or certain sort of human events that would bring people closer together. Most of them probably were not as a result of men having sex with men, but given the sort of the taboo or the stigma of homosexuality in certain areas in sub-Saharan Africa, you never really can know what the sort of social etiology of these cases are.
Exactly. In the same way that the cases here, you're not recording that information because they don't want people to be aware of it because what can happen to them if they do. And so without that information, you're left guessing.
We had reasonable efforts for mpox vaccinations in the US as of the outbreaks that were taking place. So I think that in certain areas that were folks that were at risk, I think that we've mitigated that risk to some extent. But there is still going to be a concern to have those surveillance systems in place to make sure that we are tracking it. And the theme to this too, Brad, is the fact that these pathogens, these microbes that we are discussing are global in nature. And so once we put our guards down in the US or as a result of USAID cuts impacting our ability to pick up and respond to emerging communicable diseases in other parts of the world, it doesn't mean that will not impact the United States. That absolutely will. And that's how any of these infectious diseases have ultimately scaled to become infectious disease outbreaks to epidemics to pandemics.
It's like having a smoking section in a restaurant or a peeing section in a pool. It's not going to stay in another country just because we have these borders that were drawn by someone at some point. Doesn't mean it's going to stay within those borders.
Yep.
So there's one more virus I want to talk about, one more infectious disease. While I have you, we've only like a minute or two left, so we'll do the rapid version of it. But Marburg virus from the Democratic Republic of the Congo coming up again, right? Marburg virus. First, what is it and why was it in the news? And I'm interview stacking, which I'm not supposed to do, but question stacking. Where are we now?
The short version is Marburg, the cousin of Ebola, also spread through bats. We saw the origin taking place in Uganda, and we've seen outbreaks happen every few years ever since we first sequenced this in Uganda. And there was a outbreak that took place, I think it was 2023. We're seeing it in Rwanda, and then we saw some activity in Tanzania. The good news is when it comes to Marburg, just like Ebola, it burns out very quickly. The case fatality rate is not as high as Ebola, which without any supportive treatment, for Ebola. I worked on the front lines of Sierra Leone and DRC for Ebola twice. The case fatality rate could get up to 40%. Marburg doesn't quite get there, but it does burn out very quickly because it manifests very quickly. People get sick, they die, or they convalesce. And we typically don't see it spread into urban areas, which is a really important point. If it did get into urban areas, like Ebola had gotten into Goma, for example, in DRC, which is a city, then we have significant concerns. But as long as it stays in rural areas, the concerns for spreading are somewhat mitigated.
Thank you for this crash course in the current infectious disease state of the world and the United States. And for those who are interested in his book, Pandemics, Poverty and Politics, Decoding the Social and Political Drivers of Pandemics from Plague to COVID-19. It's going to be coming out in August, and we're going to have him back on the show because we're going to be talking about the fallout from the defunding of all of our international aid and you can glean from this conversation, our domestic infectious disease surveillance. So we're going to be talking about what we can expect to see both nationally and internationally as a consequence of that. So Dr. Tyler Evans, thanks for all you do for your patients, for the world, and thank you for your time today.
Thanks, Brad.
Thanks for listening. So please share it or like it or comment on a social media post or write us a 5-star review. Thank us again for listening to The Physician's Guide to Doctoring.